So we thought we'd kind of keep that theme going again today regarding what are some actual experiences that you can take back in terms of a learning opportunity that we can have with our peer facilities here to share with you today. We had one other panelist that is not able to be with us today. Amy Butler is listed on your program as being a panelist. Amy's mother is ill and in the hospital, and she wasn't able to leave her today to be here. But we're certainly glad our other panelists are. And we've designated a certain time interval for each of them. And I know how timekeeping gets to be a little bit of a challenge, but I'm going to have to play, something. I'll do hand signals or something when we get a little long if we need to. But what we hope to do is have each of them make a brief presentation to you and save a few minutes at the end so that you can ask questions and kind of spread the knowledge of the discussion there. So let me tell you a little bit about our panelists here today. First is Stefanie Ledbetter. Many of you have had the opportunity to hear Stefanie's participation on previous panels and the contribution that she's been able to give us relative to some of the documentation and the connectivity between that documentation and the actual results that get reported to CMS. It has been pretty remarkable, the things that we've seen different there in terms of how that can drive. We've seen a lot of people being able to eliminate a lot of post-op issues because when they go into the criteria and look at it in detail, they find that they really should not be getting the negative credit that they otherwise would be getting for some of the things that are there. So a very good learning experience that we've had this past year. Stefanie is the clinical decision support and clinical documentation integrity at East Alabama Medical Center in Opelika, and again, has been a big contributor to our monthly calls as well as these panels. Betty Grubb is the Chief Quality Officer at Crestwood Medical Center. Betty's also been an active long-term participant in our committee and has brought many ideas to the table. And again, we look forward to having that opportunity to share that also today. Joan Wilder is somewhat new to our group, if you will, today. We welcome you here and thank you for your associations and the work that's going on. Joan is a certified ICD-10 trainer for Shelton State Community College, and she's a leader with the Alabama Association of Health Information Management. So we're obviously very happy to have you and also to have the other involved leaders in your association and across our state and our facilities in these discussions because we think it fosters better collaboration across all of our activities. So at this point, what we're going to do is we're going to let Stefanie go first. Betty will follow her, and then Joan will follow Betty. And I will perhaps ask a few questions in between if I think of something that needs clarifying. Otherwise, we'll save and have questions at the end. So with that, Stefanie, the floor is yours. So we look forward to your comments and your thoughts. And I believe, if I'm correct, each of them may have a little bit of a case study that they may be able to share with you of an actual patient experience so that we can kind of learn from that. And we thought that would be a good idea today. So Stefanie, thank you very much for once again joining us.
Thank you. So to level set just a little bit, and I'm going to try to make myself talk really slow. If I get to going, because I go really fast, somebody pump the brakes and I'll slow down. But to level set for you, at East Alabama Medical Center, we've been on this journey for a while. I guess 2015 and before, we've been stopping these and looking at them. And when I say stopping them, I mean all mortalities and all hospital-acquired conditions we stop. If we don't stop them because we found them ourselves, we have a really great computer guy on the backside who took our billing system and he wrote what we call failed claims edits. And he took the numerator logic for each of the hospital-acquired conditions, and if any patient hits one of those, it hits a failed claim. Even if we've already stopped it and reviewed it, it goes through and it hits that failed claim so that we double back and make sure that we have everything going on. So we also have a team. We meet twice a week, 8:30 on Wednesdays and on Fridays, and that team consists of quality, medical records coding personnel, and then also my CDI staff. And we get together and look at that patient, each mortality, each hospital-acquired condition or potential, and make sure that whatever's going out the door really represents the patient's visit at our hospital. That's all we're trying to do, is make it right. We're not trying to up or get out or whatever. It's just really about making what really happened to the patient show on that claims data. So we all get copies of the coding summary, And if you don't have access to the coding summaries, I would highly encourage you to get that. There's so much information on there, and it's so helpful. In the early phases, we not only had the coding summary, but we also got the UB. So from our billing office, we got access to that as well, because if we made any changes, there was initially a good bit of pushback about, well, we didn't change the DRG, so we're not going to drop a new claim. So we did all that. So we've come full circle on that. So to move on to my case studies, that just gives you a little bit of our process. So my first one is new for us. It's documentation of an MI as a diagnosis on a record. Used to, I was a critical care nurse. Used to, if a patient bumped their troponins, they had an MI, unless it was like very minimal, and everybody knew it. Well, medicine changes, and we know that. And so with the new evolution of the way medicine is going, there's realization that just because you bump your troponins does not mean you had an MI. Sometimes it can be due to demand ischemia or whatnot. So my first patient was, and we've had this happen 3 times in my organization, and I'll tell you how we handled it. So my first patient they said MI. The attending said MI all the way through, and he consulted the cardiologist, who said elevated troponin in the setting of demand ischemia, because the patient had an ischemic leg and they were septic, and the cardiologist didn't call it an MI. But the coders picked up on the fact that the attending called it an MI, and they went with the MI. So, and that's what they should have done. The documentation in the record, that's what they should have done. So in order to get it off, because it was not an MI, it required a phone call. And so we would not throw a query on a record for some condition like this and not discuss it first with the physician. We're really trying to build those relationships. And so the conversations kind of go, hey, we secure message, hey, I have a question about a discharged patient. It's not an emergency. Can you call me when you have time? So then they call, do you remember patient so-and-so? Yes, I do. Well, I noticed in the record that you documented the patient had an MI, and the cardiologist was consulted, but they didn't call it an MI. And I'm just curious, how do you feel about the MI? Do you feel definitively about it, or would you like to go with what the cardiologist said? So far, in all of those events, they've retracted their MI. We've done a query and placed it, and then the coder was comfortable with taking it off. So that's kind of how we handled that. My next one was a retained foreign body. We had a patient who had a history of pulmonary embolism, so we went to place a Greenfield filter. And something happened in the initial, deployment of it, and it deployed into the wrong place. Was not a problem for the patient at all. The surgeon deployed a second one and said, when I go back to get the second one, I'll get them both. To the surgeon, it was insignificant. I know this because I talked to the surgeon. So initially, there was all this discussion about, well, that's a foreign body and it's in the wrong place. It's in the right place. It's in the vessel. It's in the right place. It just didn't go where he wanted it to. So he placed a second one. So that required a conversation with the surgeon as well. And that's the thing, is engaging the doctors. And we are not perfect at that. We have so much opportunity with that because not everybody wants to be engaged. So that's really hard. It's just, anyway, and they, it's hard for the doctors. They have so many things to do. And they don't understand that here's this person yapping at them going, hey, what about? And they have to stop. That patient to them may be the last filter that they placed, and they may have placed 25 more and they don't remember. So anyway, the conversation with the doctor was, hey, I saw this happened and I'm just curious, can you tell me more? And he said, I don't really know what happened on that. It deployed earlier than I anticipated, but here's where it went. And I said, well, talk to me about the significance for the patient. Not significant at all. It's not a complication. There was no significance for the patient. And so we were able to do a query and, go from there. So, my last one, a newborn injury. So I'm a critical care nurse, emergency room, ICU. I had 3 babies, but I don't know anything about birth injury, so it's not my topic. So when I start rolling these words off, I have to do homework sometimes. And I may not know what I'm talking about to start with, but you better believe before we're done I'm going to know it, okay? So, a subgaleal hemorrhage. I said, huh? It's a newborn injury, and they said a subgaleal hemorrhage that miraculously disappeared in about 36 hours. But it's a newborn trauma. And I said, huh? And so we have up to date at our hospital. We have an access to it, and you can hit up to date. First thing I did, how do you spell that? Subgaleal hemorrhage, and it goes in, and I want to tell you what it says because I had to get my piece of paper together. And it says that it develops when blood accumulates in the loose areolar tissue in the space between the periosteum of the skull and the aponeurosis, whatever that is. Basically, it occurs in 4 of 10,000 spontaneous vaginal deliveries and 59 of 10,000 vacuum-assisted deliveries. So that said, it doesn't happen very frequently, but it happened at my hospital, okay? According to the documentation. The physician had noted, and this is what she said, that the palate was intact, caput, anterior fontanelle open, subgaleal hemorrhage spans the circumference of the head and is boggy. And then she said, impression and plan, subgaleal hemorrhage present. We'll continue to monitor the head circumference every 4 hours with vitals and whatnot. So we had a plan, that's what she thought. And she went so far as to reach out to another doctor to make sure. And there was swelling, you could see it. But less than 36 hours later, it's a normal newborn and it's going home with the mom, okay? So it's not a subgaleal hemorrhage. It was something called, and I cannot even begin to say this word, a caput something, with a swelling of the scalp above the periosteum, which absorbs within hours. And so just holding that and digging into, I know the doctor said subgaleal, and she did, but she was watching for it, but her documentation implied that she was diagnosing it, which is different. Okay, and so because we held the record, dug down into it, and everybody at the table went, oh, we would have had to transfer that baby out. It would have required a higher level of care. It would not have gone home as a normal newborn. And then everybody kind of got educated. We talked to the doctor and moved on from there. And so every one of these is different. Every one of them is different. How much time do I have? I have one more thing.
You got a couple more minutes.
Okay, one more thing. Has everybody heard of the UHDDS? Y'all know what that is? I didn't know what it was either. Have you heard of that?
I do not.
You do not. Okay. It's you know what it is, don't you? You know what it is.
I don't know if I
do.
want to know.
Yes, you do. No, it matters.
I'm not going to catch it, am I?
Hold on, I made myself a note. No, it really matters. The first time I heard it was from a coding consultant. And when she started talking about the UHDDS criteria, I said, what is that? It's like 25 data elements. They were brought out in, I don't know, 1974. And funny, even on into ICD-10, they are still valid. And this is the set of criteria that defines what your principal diagnosis is, what your secondary diagnosis is, and the administrative elements that are reported on claims that go out to CMS. So I say that to say we've recently had a couple of instances where a physician put something, a diagnosis, one time in a record or made a reference to something like in a discharge summary. We have one doctor who likes to say in the very bottom of his discharge summary, potential causes of death are not limited to pulmonary embolism, stroke, cardiac arrest. You see what I'm saying? Well, sometimes we have a coder who will want to pick those up, and our argument is we didn't treat those. We didn't evaluate those. Those are potential. He doesn't know. But the UHDDS backs up that because it goes into what is a secondary diagnosis. And so then you can say what's clinically significant and not clinically significant, and there are specific criteria for what it qualifies as a secondary diagnosis. And so that's my new nugget.
I am much smarter now that I know that.
That's my new nugget.
I think what you just told me is sometimes we can be our own worst enemy with the terms of how we start documenting in the records. Sometimes that
Correct.
lack of clarity, or at least the cover everything kind of mentality sometimes that this gets in there. Stefanie,
Right.
Thank you. And if it's all right, what I think I'll do is just wait and come back with questions, if that's okay. Mm-hmm. And that way we make sure to get through our other presenters. Okay, great. As you can tell, Stefanie always comes well-armed and has insightful information, bringing up diseases that I don't want to, oh no, it wasn't a disease, never. All right, Betty, how about you?
All right, so my journey was, came, around a little differently. We started, I was pretty into the chart abstracted measures and all that kind of thing. You always had your specification book and you always had that close and you're doing your stuff. So when the claims-based things came around, I just assumed that charting and coding was all accurate, and so I kind of came at that a little differently. So, and then I'm also coming from a facility that went from having billing and coding in-house to being farmed out. Okay, so that gave me some additional challenges. And what I think I've learned in this journey is that you have to have a handle on your claims-based measures, just like you did your chart abstracted measures, or still do with your chart abstracted measures. You have to understand everything that goes into that chart and every measure or every mechanism that gets you into the numerator or the denominator. There is no way that you can ignore these measures, because you get those rates that are inflated from what you know to be a true number. So that's kind of how I got started with this. The first case that I have is a pneumonia within 7 days of a joint. Joints are one of our bigger DRGs, so I follow that pretty closely. But in this particular case, the patient had an elective total knee, came out of recovery, was doing pretty good, had a coughing episode, and they thought there may have been some aspiration. So the surgeon decided to keep the patient in the ICU, bring in the hospitalist overnight. Hospitalist came in and said, oh, looks like aspiration pneumonitis. So patient progressed through the night, did well, had a couple of x-rays, no real treatment. X-rays both came back negative for any kind of pneumonia. Patient was moved out to the floor, discharged, and but unfortunately left with that diagnosis of pneumonitis. So we caught it pretty quickly after discharge and started that query process. Got the pneumonia removed from the coding and subsequently cleared that out of the indicator. So the second case I had is a PSI 4, okay? Death among the surgical patients with a treatable serious complication. And we never like to see these, obviously, for reasons. And unfortunately, this was a unfortunate event for a patient, but my job was to get it out of the metric. So the patient was admitted. He had come into the emergency room and was seen in an emergency room in the area. They had done some imaging and determined that his gallbladder was getting a little messy and needed to be looked at. But they didn't think it was emergent, so they sent him to a doctor. He visited his doctor about 2 days after that, and the surgeon decided to bring him immediately in and do surgery on that gallbladder. So they got him into surgery, and when they opened him up, the op note implied that the gallbladder was gangrenous. So obviously diagnosed with sepsis, and he completed, got through the surgery okay, was up ambulating, and unfortunately had some type of cardiac event. He was about 53 years old, so it was pretty unexpected. We were not able to revive him. And so he passed, and so his coding looked as if he had a sepsis following an elective surgery. And of course, the sepsis was present on admission. So we had to work a little bit on that, get that to be sure that we had the accurate documentation so we could get that coded. And then also, I think the last time that we met in October, we talked just a little bit about admit types and admit sources. And so I went back to look at that, and of course his admit type was elective. And so because he came in from the doctor's office, we were able to legitimately get that moved off to urgent. And so that removed him from the metrics. Okay. And then I do have one more.
Great example of a previously learned experience that we all learned together. So
yeah,
great work.
Thank you. Do have one more. It is a pneumonia mortality, and what you need to understand with the pneumonia mortalities is the stratification and the metrics that you have to kind of look at to be sure, because sepsis counts into your pneumonia mortalities. So you have to follow those algorithms pretty closely and make sure that you're meeting that, or you're getting out of it if you can, because it could count against you when in fact that it should not. So this particular patient was transferred from a local acute long-term facility to manage the vent. They had had some type of episode at the facility and needed to have acute vent management with aspiration. They ended up expiring the first 24 hours, so I'm not sure how long the event had happened before we got the transfer, but there was a pretty short admission period. So here I am, I've got a mortality for pneumonia, and I didn't even have a chance to do anything for the patient. So I looked at that a little closer. The primary code was sepsis. There was no severe sepsis, which is something you have to be sure of. The pneumonia secondary diagnosis was coded as POA. So they met the criteria. The admit source was non-healthcare, so it looked like they came in from home. So we changed the admit source legitimately to acute care facility transfer, and we were able to eliminate that one. That's it.
Great. Thank you, Betty. A quick question, and again, we'll save some of the questions for later. And really, I guess this is more of a question to the audience of sorts. How many of you have issues with cut and paste records in your electronic health record? I was going to say who was truthful and who wasn't. So I guess my point with that is, when Betty was describing this a minute ago, I guess I'm sitting there thinking, I wonder what that record would look like if that pneumonia or pneumonitis on your first case study you described, had that been picked up and cut and pasted by 2 or 3 other providers in the record, how much cleanup and time it would have taken to have addressed that issue. And I say that not because I have a solution on cut and paste other than eliminating it, which obviously then you got to deal with the medical staff relationship issues if that's going on in your facility. I'll leave that for all of you to figure out how well that works. But I am very concerned as I watch our industry right now. I am concerned what this cut and paste is doing to our events. But more importantly, I'm concerned of how are we going to defend ourselves in the court of law when we have to take some of these records forward and the testimony starts to unfold and the physicians have to explain why they're rolling forward a cut and paste and why they perhaps may or may not actually believe what they've cut and pasted. So again, not intended to be a criticism, but intended to just say, I think there's a danger lurking out there. I think there's sharks in the water. And I think this is something we're really going to have to watch, not only in terms of our coding and our documentation and our event reporting, but we're also going to have to watch it from a risk management standpoint. So in many cases, you may have to be the eyes and ears of your organization on that point, and to help people illustrate and understand how significant this issue could be going forward in terms of some of our records. And as you go through those records, I'm sure you're seeing it firsthand. All right. With that, we'll go, Joan, to you. And again, thank you and welcome to our group.
Thank you for having me. Again, my name is Joan Wilder, and I have, at this point in my career, kind of transitioned from the acute care setting into education, where I am training coders. So to prepare, what I had to do was to go back and interview coding managers, frontline coders, just to see what was going on in the industry. Now, to kind of tag along to 2 of the things that have already been said is the cut and paste. In addition to the UHDDS, secondary, or what qualifies as a secondary diagnosis, from a coding perspective, it all kind of goes hand in hand. Because as a coder, what the physician has documented, we should code. And what we call it sometimes is whether it's just a laundry list of differential diagnosis that could have potentially caused something, or if it's a cut and paste from another record where it's just an overlay of additional information. We are bound as coders to code what is documented. Bottom line. If it's not documented, it's not done. But if it is documented, then the coder 9 times out of 10 is going to pick that up. Especially if there is some guidance as to some sort of treatment having gone on, or to have potentially have been the cause of death or something like that. Now, with that being said, I have a couple of cases, and I also wanted to share some resources, some takeaways that maybe you might find helpful as well. In my first case, I have a 47-year-old patient who was admitted with the CSF rhinorrhea. The patient was found to have a dehiscent skull base in multiple locations along the ethmoid and with that visible CSF leak. The patient underwent that left endoscopic total ethmoidectomy, sphenoidectomy for reconstruction of the skull base defect. During that procedure, a lumbar drain was inserted and retained postoperatively to control that ICP and that CSF diversion. On post-op day number 4, lumbar drain was removed. During the removal of the drain, the lumbar drain cath tip was found to be sheared and torn without the full length of the tubing present, resulting in the retained foreign body. CT scan confirmed the foreign body that was seen in the muscles in the patient back. The patient had to be returned to OR, and the surgeon was unsuccessful in removing that tip, which upon discharge they were referred to neurosurgery. So, as with other facilities, one of the trends that I found is that there are teams of individuals, quality, medical directors, coding personnel, sometimes infection control. And we all need to bring those members to the table. But one of the things that I found interesting in one of the facilities is that they had built within their computer-assisted coding or their encoder alerts. And it was as simple as color coding that alert to the coder. So if by chance it misses the different hands, and for it to not to go out as a clean claim without any question, and for there to be discussions, there are some of the little things that we can do to alert even the coders on the what I call frontline coders as to the potential to start that discussion. And then in the second case scenario I have, which was a patient who had the BMI was 47. Went in for the gastric sleeve gastroplasty, and they too, during the surgical session, that same encounter, they realized that the temperature drain tip was retained, was missing. During that same session, they found the tip in the catheter, the suture lines. So during that session, they were able to go in and remove the tip from that probe. So even in coding it, the coder was a remote coder, yet an employee of the facility, so that coder started the discussion as to whether this could possibly be a hack. By the time the record had gotten to the coder, of course the patient had been discharged, there had been discussions with the patient by the providers of care, just to let them know that this had gone on. We were sorry. It was not significant. But in that case, you know, the conversation was generated by the coder at that point. It did not turn out to be a hack or a retained foreign object or anything like that. But again, to me, from a coding perspective, is the ability to be able to start that conversation. Okay? Two things that I would like to leave with you is, as we have been preparing this, I have been researching material. And one of the things that was published by AHIMA in March of 2019 was the Guidelines for Achieving a Compliant Query Practice Brief. This is the 2019 update that was published. I think it hit my email maybe around March the 9th. And my biggest takeaway from that is, when we're querying, it clearly defined what's a valid query and compliant query, and what is considered an invalid or non-compliant query. And when we're talking about these hospital-acquired conditions or HACs, everyone across the board, whether it's CDI, whether we're having a verbal conversation, or if it's retrospectively from the coder, what we cannot do is ask the physician in any shape, form, or fashion to try to change that documentation, because like you said, what we're trying to do, or what we should be trying to do, is right. Good or bad or indifferent. So pay attention to the information that's out there for the coders. There's quite a bit of dated information in one of our authoritative resources. There's the Coding Clinic. These are back from 2006, 2007. Yeah, they're old, but it basically reminds us that we, as coders, we have to base our decisions on that documentation. Now, if there are other circumstances, then let's have that discussion, okay? Another more recent bit of tool, AHIMA has published late 2018 the Inpatient Query Toolkit. I think it is wonderful. It is a toolkit that includes, for quite a few conditions, it's an interactive query toolkit where you can use by condition, whether it's present on admission or elective or surgery, anything that is we can do with a compliant query. We have drop-down boxes for those clinical indicators. We have drop-down boxes for those treatment options. So what AHIMA has done is given us a tool where we can be consistent in our documentation of those queries. In your facility, you may choose or may not choose to have that a part of the legal record, but what would be good to see is some consistency in what we do. And like I said, that is the AHIMA Inpatient Toolkit that was published late 2018. And that's all I have.
Great. Thank you, Joan. Appreciate it. And thank you for sharing the resources with us to be able to be used. Okay, we have a few minutes in case there are any questions out there that y'all have for any of our panelists. I think Stefanie, Betty, and Joan have done a great job, and I know I certainly appreciate them bringing the actual case studies and describing some of these circumstances, because every day is unique in our organizations in that regard. So, question right up front. Thank you. Make it an easy one now.
Who of you has concurrent coding, or is all of your coding not concurrent?
Ours, I wish. I wish. Ours is not concurrent. However, CDI, we we keep going back and forth. We were concurrent CDI. With a 24 to 48 hours after, and they were flagging things. And then last February to March of this year, we flipped into DRG validation. And now, the beginning of March of this year, we flipped back and we're doing CDI concurrent again. And so we're working together with the coders to identify. And usually if CDI sees something, they'll go ahead and put a hack pinned on it. Our system lets us do that. And if they don't, then the coders will put the hack pinned on it retrospectively.
Why did you switch back?
So that we could get a working DRG for our case management and get an expected length of stay. We had other issues that we wanted to address.
Stephanie, I might be
can I
wrong.
ask
I'm
a-
trying to recall. I think, didn't you indicate in one of the previous meetings that y'all had kind of reassigned the duties because you were trying to kind of catch up and get a head start on some of the hack events, and that caused you to reassign some of the CDI staff?
We did to a degree, but I will tell you, and I firmly believe this, we did keep one CDI staff member doing straight DRG validation to try to make sure, Medicare and focused populations, to try to make sure that we're catching it on the front and on the
Okay.
back.
And what I've seen across the board is that retrospective coding. I haven't seen anything being done concurrently. No, ma'am.
I got
I
CDI.
wish.
Y'all are all miserable like me. That's
Okay, Key.
It's
My boss often says, and this is what she says, let's pair a CDI with a coder and let's get it done at the point of care all the time. And we just haven't, we're not there yet.
The question, we're listening to questions in the back. Thank you. I don't know.
All right.
The question, thank you.
Okay. We will repeat the question. I understand that you can't hear them in the back of the room. The last question was actually related to who had concurrent coding and who did not, so that's where that discussion was coming. And it's kind of interesting to sit here as a panel today. I can recall a couple of years ago, quote, the end thing was everybody was going to concurrent coding, and yet you look in the room today and it's almost no one has gone to concurrent coding. And, I think the practicality overrode the concept, I guess. All right. Other questions in the group? Okay.
Two-parter, but the first one's real quick. What were the initials of the? I wrote down UHCDS criteria, but I think that's wrong.
This uniform discharge data is UHDDS.
UHDDS.
DDS. Yes.
Okay. All right. Thank you. And then part two, it goes to, I guess, you and Joan. So with that guidance about the queries, I guess you have to walk a very fine line. I guess if you're asking the physician, like, to clarify the MI, the cardiologist didn't agree that it was an MI, and but the discharging physician put that in the discharge summary. So, I mean, can you give us some kind of guidelines on what we can and can't ask? Because I know our coders and our CDI people, I think, are very intimately familiar with what can and can't be asked, even based on that, let's see, the first resource that you mentioned, because I think that one of our CDI guys had sent that to me and I had read it and
Yes.
wondered that. But guidance for other people that aren't as intimately involved in coding and CDI.
So most of mine starts from a quality perspective. So it was a copy paste with the MI. And I can go to a doctor from a quality because I'm not in a CDI role. They report to me, but I'm not in a CDI role. So I can go to them and say, hey, talk to me about this, or this is what I saw. Tell me what you think, and we can have a conversation. And then and CDI will come to me and say, I don't know about this diagnosis. And then from the quality standpoint, we handle and go have conversations. Occasionally, a CDI will go and have a conversation with them too. And we're very careful to ask the open-ended questions. Talk to me about this. What do you think happened to the patient? And then once we've discussed, then we place the query and the provider answers.
From a coding perspective, and what we do is all retrospectively, we cannot lead in any way.
That's right.
So we have to provide that patient's clinical indicators, okay? And we just give the physician those options as to, you said in this document it could be this, cardiologist in this case said in this document it could be that. Do you agree that it's this or that? or the other or none. I mean, but you have to give, we just can't say Dr. A is this an MI.
And I'm just a huge proponent of the conversations. We are not, my people are not in the hospital, and they'll come to me with a complex case, and the first words out of my mouth are, get walking. Go find the doctor, meet them, talk to them. Because I just think when you ask them their questions and you talk to them about it, number one, you have clinical competency, and they see that. And then number two, it makes it such that you're being perceived as helping them, especially because when they receive a query, it's just another something that they have to do, and they don't always understand, or they're in a hurry. So I just really, really, really emphasize the conversations.
And I agree. I agree, but keep in mind,
It's hard with coders.
It's hard. Most of us are remote in other states. So it's difficult. We work
Right.
non-office, non-traditional hours, most of us. So it's very hard for us to have those conversations. Now, what we do is we appreciate those conversations, but as a coder, we have to have a paper trail, if you will, of how we got to that final diagnosis. Now, if that conversation starts consecutively, or while that patient is in house, that's wonderful. That's wonderful. But if in the event it's gotten to the coder and the documentation just isn't there, then that's just our tool. That's the tool that we have.
So Stephanie, if you have the conversation with the doctor, then you say, okay.
Okay, you're talking again without mic.
If I have the,
I think one plays off the
yeah,
other.
if I
We're
have
gonna put you in the corner
Tell
of the
them
room.
be on the lookout for a query.
Right, if I have the conversation with the doctor, then I say, here's what's currently, once we talk, here's what's currently in the record. Based on the documentation in the record, it appears the patient had an MI, and that MI is going to be coded unless we do some clarification.
Exactly.
And so we can handle it one of two ways. I can send you the query and you can complete it, or I can do a verbal query with the answers based on what we discussed today, and you can sign it, and that's how we do it.
So we really have two entities that can generate a query. You have CDI that can be done concurrently, and coding that can do it retrospectively.
And for us, it just works because CDI and quality are joined. Because of the hacks, the mortalities and whatnot, we've done it both ways. We've had the most success with it being attached to quality.
All right, other questions in the very back there? Rosemary, we get to see you move.
You're waiting, Sue. So good. Thank you.
So Stephanie, when you say attached to quality, do your quality professionals get education about numerator, denominator, inclusion, exclusions for PSIs and hacks? And are those professionals allowed to interact and discuss the clinical aspects of the patient's case, or is it restricted to the CDI or coder only?
When you say discuss the patient's case, discuss with who?
The physician.
My quality people is very limited. There's only a couple of us. So I would say yes, they can discuss with the physician. I'm sorry, tell me your first part. I got lost.
No, you answered it.
Okay.
I didn't know if you restricted the conversations to only
No.
being CDI and coding.
And you know, we meet at the table with quality and CDI. The coders are remote, so they dial in. At the table, somebody has a laptop. It's usually me. If it's not me, it's one of the other girls. And we are on AHRQ. We do not print them. You cannot memorize them. You need to go to the source every single time. They're pulled up, and we're referring to those specifications every single time. If we're discussing an MI mortality, I'm on QualityNet. I'm in that manual, digging into what are the risk factors related to an MI mortality. And we're doing all of our tasks that way.
How often was the question?
How often do we meet? Twice a week. So that we don't hold up the money, because you know you hold up the money and people get upset with you. So we don't want to hold up the money.
Don't hold up the money unless you want to withhold paychecks.
That's
I'm
right.
sorry.
That's right.
Other questions? Right in the middle, yeah. I'm saving up an editorial here in a minute. Okay. But I would like y'all's reaction to it.
Some of the issues that I've started noticing is with your newer electronic medical records, the physicians go in and choose diagnoses which pull out codes. And then the coder in turn codes what the physician has put, even though the documentation in there is explicit that that was not the case. And so
We've had that a couple of times. So go ahead and finish, and I'll tell you what we did.
yeah, so I'm finding it in claim, sometimes it's in a claim base where we were talking about it's a claim-based measure. And so you don't always catch that unless you're looking at it for another reason. You know, do y'all have any suggestions for helping the physicians, you know, to choose the correct?
So when it's happened to us, we only have a couple of doctors who've done it, and when it's happened to us, the records get stopped, and my boss has come back and said, you know, they're welcome to put, one of them actually only put the ICD-10 codes, and he can't do that because nobody else knows what those codes stand for. The other providers don't know what those are, and so you have to put the words. They're welcome to put the words in whatever code they would use in their office. That's why they're doing it, is so that when it goes to the office, their office staff knows what code to key into their office system. So that's why, for us, that's why they're doing it. And so they're welcome to put the words, but our coders don't use their codes. Our coders use the words and code the record the same way that they would, whether those codes are there or whether they're not there. And that's what we've done with it.
Now, what I have seen that from a coding perspective. Now, with those UHDDS guidelines, we have parameters or definitions of a secondary diagnosis. So a list, or what may very well be a problem list of a diagnosis generated by a physician, a coder should not duplicate those codes. If that condition isn't actively being treated, something's being monitored, and utilizing resources, different things. So if that's happening, you may very well want to have a conversation with your coding manager about that, because we should not be duplicating those efforts.
Question up front.
I'm getting back.
She'll
She's
yell
running.
at you.
She's running.
Thank you.
Stephanie, what department do you fall under? Are you under finance or?
I'm in the quality division.
I bet her finance folks love her, though.
Absolutely.
Other questions? Well, while you're thinking of your question, I'm going to pose an editorial because I want to get a reaction to this. Some of the people I work with probably don't like my perspective I'm about to describe. But, you know, I see a lot of people bragging on the reports of the opportunities that have been created by the work that their CDIs do, and then they also in the coding side about we did these queries and it resulted in the following, et cetera. I guess it reminds me sometimes from a process here that we're almost congratulating ourselves for our finds without going upstream to recognizing the importance and responsibility we have for educating our physicians. I almost view a query as being a failure of the system in terms of the education that we should have perhaps engaged upon with our medical staff. That's a little extreme, but it's a little bit like patient call buttons. You know, it's almost like if we didn't do a good job of our hourly rounding, et cetera, if the patient's having to push their button all the time and ask for help. So the more buttons that get pushed, we don't congratulate people for having more calls from their patients. I'm sometimes a little leery when people hand me reports and they want to be acknowledged for the great work that's being done because of the number of queries and et cetera, et cetera. And that's all well and good. But do y'all have any comments about how you're trying to really teach your physicians, educate your physicians, change their behavior, change their patterns of activity so that this extra work you're having to do after the fact is not necessary because they did it right to start with. So I'd be curious if anybody's having any success or thoughts there. Like I said, I realize it could be a little provocative of sorts, but.
So, conversation when we got in this room this morning, not long ago we had an issue with a patient, and Brooke and Nikki sat down with the surgeon, and he went through the record with them line by line, and because of his efforts, it reversed it, okay, without going into any detail. And her comment to me this morning was, I'm thinking we probably should sit down with every single provider on every single hack and let's go through it with them one-on-one. And I see that in my future very soon. And so that's where we're kind of, but just because either they'll meet with us if they're interested and engaged and go through so that they can see how we're being measured and what we're being graded on and how it does reflect that, it's ProPublica, only because she said it to me in the last 2 weeks 10 times, but people come out with these publications and they'll say, oh, well, East Alabama Medical Center has terrible outcomes and complications. I think U.S. News and World Report did one, or Consumer Reports, and basically their methodology was flawed, but what they said was, if your length of stay was higher than the expected length of stay, then your patients had complications. Well, no, we just have a longer length of stay because we had some empty beds, and we don't have higher complications, but that's the kind of stuff that if they get a hold of this hack data and they get a hold of adverse outcomes related to readmissions and mortalities, that's the kind of stuff we're trying to hit before it hits us.
Well, I want you to tell me in about 6 months how this new activity you have that you're getting ready, because I'm absolutely convinced that there are patterns by provider, there are patterns by diagnosis, there's educational opportunities that if we fix it one time by educating, the likelihood of it being a problem down the road is going to be dramatically changed because we're changing habits and we're changing knowledge.
Yes, sir, and I agree that we should get in the habit of allowing the queries to become a learning tool. We should take that data, look at our top 10 queries, and let's educate. Now, one of the managers that I interviewed said that in a past facility that she worked, what they would do was they would look at the top 10 and educate by specialty. And she was working toward that in the newer facility, depending what the issues were. And so I think that is a good way, such as working with your surgeons. Just let's look at specialties, let's look at the top 10s, let's look at our trends and decide how we move forth in education, in educating the providers. But I do think that these tools that we use should also be extended and used as an educational tool as well.
Good, thank you.
I just wanted to say that with the joints, we meet quarterly, and so the last, I think, about 3 quarters or so, we have always had a topic regarding the complications, how you fit into those complication metrics, how you can stratify, get your risk stratification up with those surgeons. And so they're continually, and now they're starting to return, instead of just listening to me talk, now they're starting to ask questions back. So we've done this about 3 quarters, and so I'm starting to get a little bit more interest and feedback and stuff. So it's been a journey, but slowly we're getting some conversation going.
All right, great, thank you. And I think it's always helpful to remind the physicians that this profile that's being created of work at the hospital is also ultimately a profile of their service line or a profile of their practice potentially. So, they really do have skin in the game if we can make those connecting points for them. And I found that most physicians are receptive to that education. They just typically are not trained that way. They're not trained to be coders. They're not trained to think of it in that manner. And particularly when you look across the generations that are in our medical staffs, the person who's 40 doesn't work the same way or wasn't trained the same way as the one who's 60 or 70 at this point in their career.